Hello, Shelly.
Hello, sir. Good evening.
Is my voice audible?
Yes, yes.
Sir has joined. Dr. Sudhir
Yeah,
sir.
all has joined, sir.
All have joined, sir.
Give me the rights. Screen sharing, guys.
Okay,
Uh,
I'll stop share and you
yeah.
share the slide.
Okay. Thank you.
Manoj sir, you can start.
Sure. Good evening, ladies and gentlemen. Welcome to another interesting episodes of Secrets of Neurology. All of us have felt it like a knowledge feast for all neurologists. As known to each one of you, it is held in the last Friday of every month. Today we have galaxy of stars, experts, neurologists. We are extremely grateful and we would like to welcome Professor Dr. Sudhir Shah and Dr. Lakshmi Narasimhan sir. And thank you very, very much for providing those pearls of wisdom every Friday, last week of the month, sir. Today we have a warm welcome to Dr. Venkatesh, Dr. Nitika, Dr. Balveen Singh, Dr. Paul, and Dr. Monica, and of course their experts, HOD sir, Dr. Gagandeep Singh, and Dr. Rajinder Kumar Bansal sir. A warm welcome to all of you, sir. An honor and privilege for me to introduce the person who is behind this, two of our chairpersons, program coordinators and directors, Dr. Sudhir Bhai Shah, professor and head of the department, NHL, MMC and SBPI MSR Ahmedabad, and sir is director of neuroscience, Sterling Hospital, Ahmedabad. Because of his contribution to society, neurology and research, sir was also confirmed the prestigious Padam Shri in 2016, recipient of Dr. B.C. Roy Award in 2018, and also recipient of UNO Award as a Global Visionary Award. Dr. Sudhir Shah's sir interest is stroke, neurodegenerative disease, and epilepsy. So thank you for guiding us. Professor Dr. Lakshmi Narasimhan sir, Director and Professor, Institute of Neurology at Madras Medical College. Same institute he's heading where he finished his DM, recipient of many awards and affiliations, Paltusiki Advisor from AN, A.B. Baker Award for Global Best Teacher, Best Paper Award at multiple locations, to mention a few, American Academy of Neurology. His contribution to neuroscience again is immense. He has been three-term executive member in Indian Academy of Neurology, CME convener for multiple academic feasts hosted by Sir. May I invite both the chairpersons to take it forward from here, sir.
Hello. Yes, thank you. Thank you, Dr. Manoj. Thank you very much. Dr. Lakshmi, shall I start the proceedings?
Sir, please, sir, please.
Yeah, okay. Well, it's a matter of great pleasure to have all of you with us on this 8th episode of Secrets of Neurology, clinical pulse with a lot of insights in clinical medicine of neurology. And as you know, most of us are with us for all the previous 7 episodes, so it is nothing new for you. But for those who have come new today, this is basically a student-centric webinar, especially for DM and DNB neurology students, but also it has come up equally brilliant for students of medicine and freshly passed neurology guys, particularly practicing neurologists. But I got a feedback that people who are practicing neurology for years together also appreciated this webinar series. So it gives us tremendous sense of satisfaction. And I, at this juncture, would like to again thank my learned friend, my personal friend and colleague, Dr. Lakshmi Narsingh for his tremendous hard work and inputs for the success of this webinar series. I also want at this juncture to thank Mr. Chadda and his team from INTAS for this continuous medical education endeavor and their all support. Now today we have a fantastic team led by my another personal close friend, Dr. Gagandeep Singh from Danan Medical College, Ludhiana. And today the topic is also excellent. This was not discussed in any of the previous webinar, I believe. And this is on the localization on brainstem. Dr. Gagandeep Singh and his team informed me that they are not particularly likely to focus on etiology, but for a clinical neurologist, what is most important is how to accurately do localization and how to chop it medically and with radiology coherence. That is what is the theme of today's webinar. Now we have three cases. First case will be presented by Dr. Sajja Venkatesh. He is a DM resident from the Department of Neurology, DMC Ludhiana. Next slide, please. Second one is by Dr. Nikita Mahajan. She is a DM student from the same institute. And the third one is Dr. Balvin Singh from the same department. He's also another student. Next slide, please. We have a galaxy of the experts from the department. One is Dr. Monica Singla, you know, is a very famous personality. She's an associate professor of at Department of Neurology, DMC. And of course, she is a neurologist and she has 32 publications in indexed national and international journals with authorship of 14 chapters in the books, and she is recipient of brain-based brain B Regional Coordinator Award 2013, and she has a special interest in migraine, stroke, and epilepsy. Next slide, please. Next slide, please. Dr. Rajinder Kumar Bansal is another professor from the same institute. He is an organizing secretary, 69th Annual Conference of API. He is the organizing secretary of Indian Epilepsy School 2015. He is the organizing secretary and teaching course of cognitive neurology, governing body member of API, and he has also more than 15 national and international publication journals. Next slide, please. We have Professor B.S. Paul, Virinder Singh Paul, who is also from the same institute, and he has more than 40 publications, 17 chapter in books, and his area of interest is movement disorder and critical or autoimmune disorders. Next slide, please. May I have the next slide, please? We have Dr. Gagandeep Singh, professor and head Department of Neurology, DMC Ludhiana. I mean, who needs introduction of Gagandeep Singh? He is our beloved immediate past secretary of Indian Academy of Neurology for 6 successful years. He is DM, FMS, FRCP, and he is also fellow of National Academy of Medical Science, fellow of Royal College of Physicians London, is PIAN and fellow of Indian College of Physicians. He has lots of honors, but particularly the honorary associate professor of Department of Clinical and Experimental Epilepsy at the UCL, Institute of Neurology, Queen Square, London. It's a rare honor, I will all agree. He is also recipient of Dr. B.C. Bansal and Uma Bansal Oration Award, Dr. C.S. Sainani Oration Award, and I think he's touching now 100 publications in national and international journals. As we all know, his main area of interest is epilepsy and training of the student with zeal and zest. So with that, I would invite the coordinator from Ludhiana to start the proceedings. And the the flow will be like this. There will be 3 cases followed by immediately followed, each of them will be followed by some clinical discussion and then special comments, localization comments, pulse, and radiology correlations. Thank you very much for being here and putting trust in me and Dr. Lakshmi. Thank you once again.
Thank you, sir. At the outset, I would like to thank Dr. Sudhir Shah and Dr. Lakshmi Narasimha to give this opportunity to Department of Neurology, DMC Ludhiana, headed by Dr. Gagandeep Singh. This presentation, as pointed out by Dr. Sudhir Shah, is little different. So Dr. Gagandeep actually has put in a lot of hard work. Every finest detail has been looked up by him. The protocol has been told by Dr. Shah that there will be 3 cases. All 3 cases will be discussed by residents. Then followed by comments by the consultants. The 3 cases, first case will be how to do diplopia charting in routine clinical practice. Second case will be to illustrate salient clinical signs of focal brainstem lesions. Third will be to demonstrate clinico-radiological correlation of these signs and to extrapolate brainstem anatomy on MRI scans. So this will be the brief outline of our presentation. And there is no conflict of interest, and we acknowledge our patients have given consent to use their videos and photographs. Before I hand over to our moderator, to Dr. Gagandeep Singh, I would like to invite all of you and your friends to Tropical Neurology Conference, which is to be held on 27th, 28th, and 29th March. This will be held between 4 p.m. and 9 p.m., so 5 hours every day. This conference has 15 sessions, 9 keynote lectures. This lecture list has been shown on the screen. There is a CPC on 27th March. There is a quiz on 29th March, and there are posters on 28th March. And there are 8 panel discussions. One on rabies, then progressive myelopathy, leprosy, mellitus, NCC, TBM, lead poisoning, and subacute combined degeneration. So all of you are welcome. Please spread this information in your colleagues, and detailed information about the scientific program and registration details you can look at www.iantncon.com. Over to Dr. Gagandeep Singh, sir.
Thank you, Dr. Bansal. And thank you so much, the organizers, Dr. Sudhir Shah and Dr. Lakshmi, for this wonderful opportunity to our department. Our residents are extremely thrilled. They've been working extremely hard over the last few days, polishing their cases and polishing their presentations. As Dr. Bansal clearly emphasized, we are going to focus on the brainstem. Brainstem is also quite huge. I mean, there are lots of tracts. We all know the anatomy of the brainstem. That's basic, something basic, which when we start off neurology, we emphasize brainstem anatomy, brainstem tracts, the study of brainstem nuclei to a great extent. But then localization is a different ball game, as you would see in these cases. We are only going to deal with some selected aspects, and as Professor Shah and Professor Bansal emphasized, the scope of today's meeting is on localization, and we choose not to discuss etiology to a great extent. However, if there are questions, we'd be happy to answer. With this, we go on to the first case. Is a very short case, and the second case is somewhat longer, and the third case somewhat more longer. And so we will take it as it comes. Venkatesh, are you ready with the first case? Are you ready with your slides? You need to share your screen.
Yes, sir.
If there are questions, if there are comments, please use the chat box. We'll keep checking the chat box every now and then and taking questions as they come. Thank you so much.
Right.
Venkatesh,
Yes, thank you
please.
for the introduction.
Yes.
So, ladies and gentlemen, I'm going to start with the first case. So, we have an 18-year-old male who doesn't have any previous comorbidities, and he presented to us with chief complaints of double vision and decreased hearing on the left side. So, his double vision was mainly binocular, and it used to worsen on looking down, and the images were separated vertically. And also, the hearing loss was on the left side, but it was not associated with any tinnitus, vertigo, or any oral fullness or otalgia. And these complaints were sudden in onset, and they were gradually improving for the period of past 10 months. And these were not associated with any diurnal variations. And the patient presented to us for persistent symptoms over the past 10 months, although they were gradually improving. And he does not have any associated headache or ocular pain or any speech disturbance or any sensory or motor symptoms. And also he doesn't have any history of trauma to the eye or face or head. So this was the history in short. And now coming to the examination, the patient was conscious, cooperative and oriented. And on cranial examination, there was no ptosis, and the pupils were bilaterally equal in size, about 2.5 mm, and they were equally reactive to light on both sides. And on hearing test, we found that the Rinne's test was positive bilaterally, which means that the air conduction is more than bone conduction. And the Weber's test, it lateralized to the right side. So it means that he has sensory hearing loss on the left side. Also, the Schwabach test confirmed the same. The patient's bone conduction was worse compared to the examiner on the left side. And the other cranial examinations were normal. And also the motor and sensory system examination was unremarkable, and there were no cerebellar signs. Now coming to the extraocular movement examination, we did a diplopia charting for the patient. So this is how the diplopia chart looks. So to start with, if you see the instrument used, we have a goggles which has red and green colored. So the red color goes on to the right eye and the green color goes on to the left eye. So the picture here is a representative image, not of the patient. And we have three colored sketches, the red, orange and green. So here we can see the torch, which has a vertical slit. So we project the light after the patient wears the goggles. And we project the light in all the 9 cardinal directions of the gaze, right? And then we ask the patient to draw the lines as he sees it. So if he sees a single line, it will be of orange colors. The combined red and green will give a orange light. And if he sees 2 separate images, they will be of red and green separate, coming from the red and left eye respectively. And so here the diplopia chart is represented as the patient sees it. That is, the right over here represents the right hemifield of vision of the patient, and the left represents the left hemifield of vision of the patient. So this is the chart in the 9 cardinal directions of the gaze. And here we can see the patient sees single line in all the 7 cardinal 7 directions, except for 2, particularly in right lower gaze and on right gaze. So he sees 2 separate lines which are red and green colored. And as we can notice here, the lines are separated more in the right lower quadrant or the right inferior quadrant. The distance between the 2 lines is greater. So this was the diplopia charting of the patient.
Venkatesh, I'm going to ask you some questions now.
Yes.
So based on this diplopia charting, which muscles do you think were involved in your patient? Which extraocular muscles do you think were involved in your patient?
Right, sir. So as we have seen in the charting, the images were most widely separated when an attempt is made to look in the right inferior direction. So if you see the rules of diplopia, the images are generally most widely separated when an attempt is made to look in the direction of the paretic muscle or the weak muscle. So in this case, we have a separation of images, which is more in the right lower quadrant. So if you look at the muscles acting in that direction, in the right lower quadrant, the 2 muscles are the superior oblique of the left eye and the inferior rectus of the right eye. So these are the 2 muscles which act in the right lower quadrant. And so in the next step, if you see the green image was the lower or the peripheral one, and the red line is the image coming from the right eye. So the peripheral or the false image, which is the green one, is coming from the left eye. So the false image is the most peripheral image, and it is displaced in the direction of action of weak muscle. So here in this case, the green image, which is more peripheral, is the false image, and it is coming from the left eye. And so we can conclude that among the two muscles, the left superior oblique muscle is the weak muscle or the paretic muscle.
Okay, thank you,
Sir,
Venkatesh.
So with the permission, can I ask one small question to him, sir?
Sure, yes.
I
yes,
just wanted
okay.
to, normally the horizontal diplopia charting and vertical diplopia charting, no? The two things, one is both charts to be done, or is it or represented in the same chart?
Since the complaint is vertical suppression, we did it horizontal lines. If your patient has a horizontal diplopia complaint, and then we can do it the vertical.
Yeah.
Normally,
Yeah, but what
normally the
Dr.
horizontal one are with vertical lines, and the vertical ones are with the horizontal lines.
That's
Huh?
Yeah, what Dr.
Yeah.
Lakshmi is saying is right. We need to do it in both the horizontal as well as the vertical, but we have a beautiful talk after the case presentation on
Sure,
how
sure,
to do
sure.
diplopia charting,
Go ahead,
which
please. Go.
Dr. Monica would be presenting that. But yes, exactly what you're saying is right. And Venkatesh, so you think this patient had a left superior oblique palsy?
yes, sir.
So, yeah, no, so, you've told us the history, you've told us the examination. The examination generally points to where is the lesion or the anatomical site of the lesion. The history tells us what is the lesion or the etiology. Now that you tell us that the left superior oblique is palsied, I want you to please tell us which side trochlear nerve or trochlear nucleus is involved. Obviously, it's a nerve palsy. So we want to know which side is the trochlear nerve palsy.
So if you remember, the trochlear nerve supplies the contralateral muscle. So that is the left superior oblique muscle receives supply from the right trochlear nerve or the right trochlear nucleus. So the right trochlear nucleus supplies the left superior oblique, and the vice versa, the left trochlear nerve supplies the right superior oblique.
Venkatesh, do you have a diagram to supplement
Yes.
it? Oh, right.
So this is the MRI imaging of the patient. So as we expected, the lesion is in the right side of the brain. So these are the axial cuts, and as we can see here, this is the right of the patient, this is the left of the patient. And the first image is the T1 sequence, and the second is the flared sequence, and these are at the level of the lower brainstem, lower midbrain. Whereas the third one is a flared sequence again, which is at the level of the rostral pons or the pontomesencephalic junction, and all of these are axial cuts. So here we can see the patient has a lesion on the right side, basically in the dorsal region of the lower midbrain, and also at the region of the rostral pons or the pontomesencephalic junction, again on the right side and dorsally. So this indicates the involvement of the or probably a right side trochlear nerve or its nucleus or its fascicular involvement on the right side. So as we can see here, this is a same image. We have blown it up and we have inverted it. So this is the left of the patient, this is the right, and this is posterior side, whereas this is the anterior side. So here we can see the lesion lies in the tectum of the midbrain at the inferior cortical levels. And if we see closely, this is the area where the trochlear fascicles pass through after rising from the trochlear nuclei. And in the dorsalmost region, they actually cross over within the brainstem, and then they go on to the opposite. So the right trochlear nerve supplies the left superior oblique muscle, and similarly the left trochlear nerve supplies the right superior oblique muscle.
Right. So this is clear that we have involvement of the right trochlear nerve leading on to a left superior oblique palsy.
Yes.
Right. So Venkatesh, can we go further? And how do you? This patient also had hearing loss on the right side. Now there is
yes, on the left side.
On the left side, yeah.
Yes.
So we have to explain the hearing loss. And we all know about Occam's razor and Highcomb's dictum, right? Occam's razor is when you try to explain everything with a single lesion, while Highcomb's dictum was, any person or any patient can have any number of lesions, right? So I want to know, are you a protagonist of the Occam's razor or you are a protagonist of Highcomb's dictum? Do you think the deafness on the left side can be explained by a single lesion, or do you think you want to bring in two lesions?
So generally going, I'm protagonist of Occam's razor.
Okay.
However, the sensory hearing loss, which is unilateral in this case, it is very rare that we see a patient having unilateral sensory neural hearing loss with a brainstem lesion. So in most of the cases, unilateral sensory neural hearing loss is expected to be a lesion of either the cochlear nucleus on the cochlear nerve or the cochlea on the same side. So very rarely we see cases with a sensory neural hearing loss which is unilateral and with a lesion on the opposite side of the brainstem. So as we can see here, this is the inverted image. Again, this is at the level of the rostral pons of the ponto-mesencephalic junction. And here we can see the lesion, which is on the right. This is the right of the patient and this is left, and this is the dorsal surface. So the lesion here is on the right side on the dorsal surface of the rostral pons. And this is region where the lateral lemniscus passes through and relays in the inferior cortex in the midbrain. So here we see the hearing pathway starts from the cochlea and via the eighth nerve reaches the cochlear nucleus. And from there, there is decussation. Some fibers pass through the ipsilateral superior olivary nucleus and some fibers pass through the contralateral superior olivary nucleus. And this crossover takes place in the trapezoid body. And from here on, the fibers pass through the lateral lemniscus and reach the inferior cortex in the midbrain. And from there, they again pass to the medial geniculate body of the thalamus. And from there, they pass to the temporal lobe cortex where the acoustic area is present. So inside the brainstem, after the cochlear nucleus, the central auditory pathways, they have decussations. And so that the central auditory pathways receive bilateral inputs from both the ears. Whereas at the level below the cochlear nucleus, the input is mainly unilateral or ipsilateral. But in the brainstem, the central auditory pathways, they receive bilateral inputs. So we don't expect a lesion, so we don't expect a unilateral hearing loss with a brainstem lesion. However, in rare cases, we can see this. So following this, we have reviewed the literature. So wherein we found a few case reports where there was lesion in the lateral lemniscus in the brainstem with a contralateral sensory neural kind of hearing loss. And most of these case reports are above 50 years, and most of these patients were having infarcts in the mid pons or the rostral pons, and also a patient in the left lower midbrain.
Thank you. And thank you for the case reports and showing us all the cases.
Right.
Hello.
Yes,
Can you
sir.
hear me?
Yes, sir.
Right. Okay. Why is there a background noise? Can I? There is some kind of background noise.
Sir, I muted.
Right. Okay. So now is everyone clear? Hello. Hello.
Yes, sir.
So Venkatesh, so your final diagnosis is, yeah, it would be interesting, but probably we need to go back and look at the audiometry and see if there is any hearing loss because of lesion in the left ear, internal ear, or perhaps in the nerve. So that is something that we need to see. But this was a very short case, ladies and gentlemen, a very short case, just emphasizing the importance of localization and how we can correlate the clinical diagnosis with the anatomical diagnosis on the magnetic resonance imaging. Thank you, Venkatesh, for a brief, lovely, and excellent presentation. We go on to a discussion subsequently on how do we do diplopia charting and the technique of diplopia charting, and Dr. Monica Singla, who is associate professor in our department, has prepared a very excellent video. I request her to go ahead with the video and tell us how to do diplopia charting. Thank you.
Ma'am, can I play?
Yes, please.
Yes,
Yes,
Sally.
please.
Yeah.
Good evening, everyone. In today's session, as we know that we are going to discuss about diplopia cases. So it's very important to learn how to do diplopia charting. As for diplopia, it's important to localize that which muscle of the eye is involved and where the lesion is in the brain. So before we begin with the diplopia charting, I would like to explain about what are the prerequisites for doing diplopia charting. First of all, diplopia charting has to be done in semi-dark room. Second thing, the distance between the subject as well as the examiner is very important. We can see here there are two chairs. This chair is for the subject and the other one is for the examiner. The distance between the two chairs has to be about 4 feet, or we can say 1 to 1.5 meters. And the subject has to sit near the table so that he can draw the diplopia chart. So, for diplopia charting, we need this kind of paper where we have drawn 9 boxes. Another thing required is, which is the most important, is the red and green glasses, that is Armstrong goggles. Here we can see we have two glasses, one is red in color, other is green in color. It's easy to remember how to wear it. R for red, R for right. So, when the subject will wear, this red glass will come on the right side and the green will come on the left side. Second thing, we have this torch which has a slit-like light. So, this slit-like image we have to see to the show to the patient. It will be vertical when we are doing the horizontal diplopia charting, and we'll show it as a horizontal slit when we are doing the vertical diplopia charting. Then we have 3 markers. One is red in color, which has to be on the right side of the subject. Then green in color, which has to be on the left side of the subject, and orange in color. These 2 colored pens will be used when the subject is seeing 2 images, red and green. If he sees one image, then it will be orange in color, then he has to draw with the orange pen. So now we'll begin with the diplopia chart. Hello Deepak, today we will do the diplopia charting. Okay. So before we start with the procedure, I'll explain you everything how we'll do this diplopia charting step by step. So you can see you have few things in front of you. Yes. This is a diplopia chart, yes, which has 9 squares, right? Then you have one glasses. These are Armstrong goggles with red color on one side and green color on the other side. On your right side, there is a red color. Yes, ma'am. So then you have 3 markers. One is red, one is orange, one is green. On your right side, it is the red color. And I have a slit-like light with me. Okay. So when we start, we'll do in a semi-dark room. I will start, when you wear the glasses, I will put the slit light on your eyes. I'll start from the center. Then I'll go on the right side, then come to the center again, then left side, then up and down, and then all the other lateral quadrants, up and down, right? Okay. So whenever you see the light, when I put the light on the center, you will see the images. If you see one image, it will be usually in the orange in color. Then you have to draw the one line in this square, okay? So if you see 2 images, these may be red and green in color. So you have to draw 2 lines, but you have to see which line is on which side. Accordingly you have to draw. Then you have to see how far the images are. Accordingly you have to keep the distance. Third thing, whether they are bright or less bright. So you have to tell me that. So shall we start, Deepak? Yes, you are ready? Yes, I am ready. Okay. Deepak, please wear these Armstrong goggles. many images can you see, Deepak?
I can see one image in orange color.
Okay. Can you draw the image in the central box
Yes, ma'am.
with the orange pen?
Yes.
Thank you, Deepak. So now we'll move towards the left side.
Yes, ma'am.
Deepak, can you see anything?
Yes, ma'am. I can see one line in orange color.
Okay. Please, Deepak, draw this in the left box.
Yes.
Again, I'll come to the center, Deepak. Then I'm going towards your right side.
Yes, ma'am.
So can you see anything?
Yes. On my right side is an orange color in single line.
So there is a single line.
Yes, ma'am.
So please draw it in the right square. Again, coming back to the center, I am going up.
Yes.
Deepak, can you see any line or image?
Yes, ma'am.
How many?
It's a one line again in orange color.
Okay, please Deepak, draw it in the upper square. Again, coming back to the center, I am going towards down. Deepak, can you see any lines?
Yes, ma'am.
How many lines, Deepak?
One line, ma'am.
One line. So please, can you draw it in the lower box?
Yes. It is in orange color. Yes.
Thank you. Again, coming to the center, I am going towards your right, this left upper quadrant. Okay?
Yes.
Can you see anything, Deepak?
Yes, ma'am.
How many images?
One image is, ma'am, orange color.
Okay. Please draw it in the left upper box.
Yes, ma'am.
Again, coming to the center, I am going towards your left lower quadrant.
Yes.
Okay. So can you see any line?
Yes, ma'am.
How many?
It's one line.
One line only?
One line
Orange
only in
color?
orange color.
Okay, please. Coming back to the center, I am going towards the right upper quadrant diagonally. Can you see any image, Deepak?
Yes, ma'am.
How many?
It's again in orange color and single line.
Single line?
Yes.
So please draw it in the right upper box. Thank you. Coming to the center again, I am going towards the right lower quadrant diagonally. Can you see anything, Deepak?
Yes, ma'am.
How many images?
One image is, ma'am, orange color.
Okay. Please draw it in the. Thank you, Deepak. So now we are done with the diplopia chart.
Okay.
Thank you.
Thank you.
Deepak, can you show the diplopia chart?
Yes, ma'am.
Okay, Deepak. Thank you. Perfect. Thank you, Helly. Can you stop sharing? So I'd like to mention that I like to show this diplopia testing kit to all the residents sitting here, that this can be kept in the departments everywhere. It's a very handy kind of kit. In this kit, we have these Armstrong goggles. These goggles are easily available on Amazon. And the price is about, I think, 650 or 670 rupees. That's the only cost we have to bear for this diplopia charting, as this is a routine torch which we had. So we have put this tape and to make a slit for this torch. And we just need 3 colored pens. So this type of diplopia kit can be easily made in the departments, and we should be keeping for our clinical examination. Balveen, can you start sharing the screen? Thank you. So I'll be showing just 2-3 diplopia charts and tell how to analyze these charts. So here in this slide, we can see that these are the vertical images. So this chart we have drawn for a patient who is complaining of horizontal diplopia. So we can understand there is a horizontal separation of the images. As I told, you can see here, this is the right side, this is the left side. As I told in the diplopia charting, that on the right side, we have the red light or red image. So ideally, there has to be the red image on the right side. So if the green image is coming on the right side, it means it is crossed diplopia. And we can see the maximum separation of the images is in the right direction, looking towards right. And this separation is absent on the left gaze. So this image is suggestive of, this diplopia charting suggestive of left medial rectus palsy. If there would have been this red line here and the green line here, then we should have called that it is a horizontal diplopia with uncrossed images with maximum separation in the right gaze, with absence of any separation on the left gaze, then we should have called it as a left lateral rectus palsy. Okay, going to the next slide. So here we can see we have drawn this diplopia chart with horizontal images. So it means this is a diplopia chart of a patient who is complaining of vertical diplopia. So again, if we analyze these images, we can see that this green image is coming towards on the outer side as compared to the red. Third thing, there is a maximum separation of images going towards left gaze and in the left lower quadrant, and it is less on the right gaze. So this diplopia chart is of a patient who is having left inferior rectus palsy. Next slide. This is the chart which Dr. Venkatesh has shown already. So just to make a comparison and to make things easy, and we can remember that how we can differentiate from the inferior rectus palsy from the superior oblique palsy. We can see here in this chart that there are two images again. The red image is on the outer side, so it is on the right side. And there is a maximum separation on right gaze, that is a dextro depression, we can say on the right side in the lower quadrant. So, and this separation is absent on the left gaze. So this is suggestive of left superior oblique palsy. One thing easy to remember, that vertical recti, if there is a vertical rectus palsy, the diplopia is crossed or images are crossed. But if the obliques are involved, then it is uncrossed. Thank you. So this was the diplopia charting. If any questions or queries, you are most welcome to ask. Now I would request Dr. Nitika to present the next.
Thank you so much. And thank you for the excellent overview of diplopia charting. And I hope that all present here, particularly our younger colleagues and residents, are motivated now to purchase these diplopia kits. It's just an Armstrong goggles which can be ordered on the Amazon and then go ahead with diplopia charting. With this, there are a couple of questions. We can rapidly take up those questions. One is, was there any involvement of the right facial nerve? The answer is no. Someone has said, there is a question, auditory pathways from the right nerve reach two cochlear nuclei. From there, the crossing over takes place between the two cochlear nuclei, to the right and left. So if both nuclei on the right is involved before the decussation, will it explain hearing loss on the left side? So here we have, see, the decussation takes place at the level of the trapezoid body, which is lower pons, right? Fine. Right, right. That is where the decussation takes place. Now we have a lesion on the right side in the midbrain after the decussation has taken place. So that lesion is on the right side, and therefore it can explain the left sensory neural hearing loss. I mean, it is just a conjecture. The right way to confirm it is to do audiometry and do a brainstem auditory evoked response and confirm whether and exclude a lesion of the left auditory nerve, right? So I guess questions are taken. So we go on to the second case. Can I request Dr. Nitika Mahajan, resident in the Department of Neurology, to go ahead, present the second case. Dr. Birinder Paul will discuss the findings of the second case.
A very good evening to all present. So we'll be continuing with the second case of the evening. The subject is a 32-year male who presented with a complaint of difficulty in walking and maintaining balance, dysarthria, double vision, and there were no comorbidities. These complaints were just 1 week prior to admission. So this is the video which is showing the examination findings of the patient on admission. In the first half of the video, we'll be looking at the cardinal positions of the gaze. In the second part, we'll look at the examination of the 7th cranial nerve. And in the third part, we look at the cerebellar signs. So now I'll play the video and try to explain the findings side by side. So we ask the patient to look towards the left side. He can do so. Now we ask him to look towards the right side. Then again to the left side. He can look towards the left side. So up till now, we were looking at the horizontal movements of the patient. He could look towards the left side, but when asked to look towards the right side, he could not do so. So there was a right gaze paresis in this patient. Now we look at the vertical movements of the patient. On telling him to look upwards, he can do so. Downward movement is complete and fine. So now we'll look at the 7th cranial nerve examination. We ask the patient to show his teeth to look for volitional 7th nerve palsy. And as we can see, there is no facial asymmetry at all. And hence the patient does not have volitional 7th nerve palsy. Now we ask the patient to crack a joke. We can see the moment he starts laughing, there is drooping of the nasolabial fold of the left side, suggesting a 7th cranial nerve palsy, which was elicited on laughter of the patient. So the finding was there was no volitional 7th nerve palsy. However, on laughter, the 7th nerve palsy appeared on the left side. Further, we examine the cerebellar signs in the form of finger-nose test. We can see that there is dyssynergia and dysmetria on finger-nose testing on the left side. And same is the case on the right side. So the finger-nose test was impaired bilaterally, more over the right side as compared to the left side. So now we club together these findings. Our patient was calm, conscious, oriented to time, place, and person. Dysarthria was present in this patient in the form of abnormalities in articulation and prosody with labored speech production. The right horizontal gaze was impaired. Facial asymmetry on the left side appeared on laughter. Finger-nose test was impaired bilaterally, and the sign was more evident on the right side as compared to the left side. Further, these are the MRI findings of our patient. So the above pictures in the first row, these are the FLAIR images, while the ones on the next row are the T2 images of these patients. This is the right side, this is the left side, this is the ventral part, that is anterior part, and this is the posterior part. So in these sections, we are going from above to low. So this is the upper midbrain, this is lower midbrain, this is the pontomesencephalic junction. That is the beginning of the pons. We can see that the 4th ventricle has started forming here. This is the upper pons and the lower pons. So what we can see is that the major chunk of the lesion was on the right side of the dorsum of the pontomesencephalic junction in this patient. However, upper pons was also involved on the right side dorsally, and there was some involvement of the inferior midbrain. So these lesions were FLAIR and T2 hyperintense. So now when we discuss these findings, we have certain questions that come to our mind. Is there any facial paresis? Explain the differences in the facial contour during volition and elicited laughter. How do we knit together the above mentioned findings of presence of bilateral cerebellar signs, presence of left facial paresis on laughter, and right gaze abnormality? Now I request Dr. B.S. Paul to take over these questions and explain the clinico-radiological analysis of this case. Thank you.
Thank you, Nitika. Sir, should we go ahead?
Yes, please. Yes, please.
Okay. So good evening, everybody. We know that the neurology cases are always brain teaser type of question. And to solve any puzzle, we have to put the right puzzle piece in the right place, then only we are able to. So this is what we try to do in this patient. First of all, it appears that there is involvement, as she has highlighted, that sixth nerve involvement is there, seventh nerve palsy is there with cerebral ataxia, predominantly involving both sides of the body. So initial we think it could be in the pons, but as we see that the major chunk of the lesion was on this MRI was in the pontomesencephalic or in the midbrain. So to our surprise, there was no lesion which could explain all these findings in totality. So following the same Hockham dictum, we tried to explain these findings with our, so we again, let us have a relook at the signs which we noticed. First, this was what is there. So definitely there was voluntary facial sensation. Voluntary facial is preserved with predominant emotional involvement. So this was an emotional or mimicked facial palsy without volitional facial palsy. This is very important in this patient. And we know that emotional and voluntary facial movements are clinically dissociated. Voluntary and emotional information converge through a separate supranuclear pathway to the seventh nerve nucleus, and the presumed or the what the literature suggests that emotional fibers, they start from the precentral gyrus or probably in the insular, and they follow the route of thalamus, dorsal midbrain, and to the seventh nerve nucleus. There is even literature suggests that these fibers, they don't go through the internal capsule. So it has been seen that emotional facial palsy can be seen in patient in lesions which are present in the basal ganglia or in the thalamus, even in the temporal or frontal lobes. So now we have tried to draw it, although in literature there are no pathway which is mentioned or drawn for the emotional fibers of the face. This is what we learned, and we learned from the literature that there are probably from the frontal area, thalamus, these pathway converge separately to the seventh nerve nucleus. So this is the seventh nerve nucleus. This is lower motor neuron. This are the voluntary fibers which are coming, and they going to the seventh nerve, and this is the emotional fiber. So with this, we try to explain the lesion. This is the blown up image of the same person. This is the right side because we have inverted the image. So this is the left side. This is the ventral part. This is the dorsal part, and this is the region. So probably this is the supranuclear emotional fiber of seventh nerve which is passing through the midbrain and going into the seventh nerve nucleus in the pons where they are involved. One. Secondly, this we try to explain the first sign. Going to the second, there is the left side gaze movements were normal. Horizontal eye movement on the left side were normal. Right side, there was impairment in the horizontal eye movements. Down, vertical eye movements are normal both in the up direction and the down direction. So we have a subject who had predominant involvement of the right gaze, horizontal gaze. So again, going back to the same image, this is the right side, this is the left side, inverted image, dorsal and ventral. So these are where the supranuclear excitatory pathway, they pass through the midbrain just close to the third nerve nucleus, where they go to the sixth nerve nucleus. Probably this is the descending supranuclear pathway to the sixth nerve nucleus, which could explain this impairment in the horizontal gaze in this subject. So coming to the third sign, which was predominant sign noted in is the cerebellar involvement, which was bilaterally. So we know that cerebellar signs can be because of cerebellar lesion itself or its connection. And cerebellum is connected to brainstem by three large peduncles: the inferior cerebral peduncle, middle cerebral peduncle, and the rostral cerebral peduncle in the midbrain. So, and this patient has asymmetrical cerebellar involvement with dysarthria. And dysarthria is of articulation, prosody, and difficulty in speech. So the ataxia being asymmetrical, let us go back to the anatomy. We know that in the inferior collicular level of the midbrain, there is the decussation of the cerebellar fiber, which occur in the ventral part just close to the midline. So here is the lesion in our patient also. So there is decussation, involvement of the decussating fiber, which was responsible for presence of bilateral asymmetrical cerebellar signs. So now summing up that, first, this is the images which has been inverted. So first he had emotional facial palsy. So these are the emotional descending fibers which are involved in the midbrain reticular formation. Second was the restriction of the horizontal eye movement, probably horizontal gaze palsy. So this because of the involvement of supranuclear descending fiber to the sixth nerve nucleus. Third, he has bilateral cerebellar sign. Again, because of bilaterality in the cerebellar sign, there may be a lesion which involved in decussing cerebral fiber in the midbrain, lower part of the midbrain. So when we searched up the literature, we found there was a very interesting article, although it was old article, which says that the emotional information descend mediodorsally in the midbrain. Emotional response fiber converge below the level of voluntary fiber. And definitely there are two separate pathways for the emotional fiber as well as the volitional or voluntary fibers. And they converge, they remain uncrossed till mid one third of the pons before they converge on the nucleus. Coming to our second symptom, that is the restriction of the horizontal eye movement. When we searched the literature, there was a paper in which it initially was coined as a posterior internuclear ophthalmoplegia of Lutz. It was published in BMC 2001, where they have found, plus it is a retrospective analysis of 22 patients, where they found that there was prenuclear abducens nerve palsy in the midbrain. And the explanation was that this paper was even corroborated with the electrophysiological evidence of involvement of the midbrain by doing the blink reflex, by doing the jaw reflex, as well as electrocurrent oculography and BERA. So by this, they were able to localize the patient who have right horizontal gaze limitation, that the lesion was limited in the midbrain. So they propose that there is supranuclear pathway for lateral gaze, which runs near the third nerve nucleus, and this descending excitatory supranuclear fiber mediate the horizontal gaze. And probably if we go back to our patient, this patient have additional signs which suggest that because of bilateral cerebellar involvement, there is lesion probably in the midbrain or lower midbrain at the level of inferior collicular level. So thank you.
Thank you. Dr. Birinder, thank you for explaining everything in such a lucid manner with beautiful diagrams. There is one question, Dr. MK. I think you have partially answered the question, but probably you need to elaborate a little more. And the question quite appropriately is this a INO, and what are the differences between anterior and posterior INO, which is basically what you have said, the paper that you showed. But would you like to say a few words more about it and the differentiation between anterior and posterior INO?
Yes, sir. Probably initially it was in that paper, it was mentioned that it was posterior INO, but subsequently they found that it is a wrong point term. And regarding the INO, if there is involvement of convergence, then it is probably a posterior INO. But if we see in this patient, what is happening, that what happens in INO? INO, there is impairment of adduction in one eye with abducting nystagmus in the other eye. Whereas in our patient, if we see on the ipsilateral side, there is impairment in the abduction rather than adduction of the eye. And on the other side, there is also impairment in the adduction. So there is no nystagmus, it is rather other way around. There in INO, you will have adduction and abducting nystagmus. But in here, both the movement of adduction on right side and abduction on left side involved, suggesting that probably it may not be INO, it is horizontal restriction of eye movement is there.
Okay, thank you. I hope that clarifies. If there are, do you want to sum up, or is that the end of the case, and should we go on to the
next?
This
is the end of the case. We thought
Thank you. Thank you so much, Dr. Birinder. Beautifully elucidating all the signs, and particularly the nice diagrams that you had made. So we go on to the third case. Meanwhile, there is one question by Dr. Atif Kavusa. Is it a right trochlear nerve? Do we call it a right-sided, or is it left-sided? I think the next case clearly is also will emphasize how to differentiate between a right and left trochlear nerve palsy, so that there is no right-left confusion or no Gerstmann syndrome for this. With this, I call upon Dr. Balveen, who is also just second case diagnosis. Right. Dr. Birinder, you want to, yeah, we were not planning to discuss the diagnosis. Dr. Birinder, would you like to tell very briefly in a couple of lines what the diagnosis eventually turned out to be?
Yes, sir. Definitely. This patient, this patient after 15 days presented to us with the new symptoms of aphasia, as well as there was right-sided hemiplegia now. So when we did a repeat MRI, there was new lesion involving the right cortical area as well as right temporal area. When we biopsied that area, it was found that there was vasculitis. There was invasion of the vasculitis. So our final diagnosis was vasculitis, CNS vasculitis.
So this is biopsy proven primary CNS vasculitis.
Yes, yes, sir. Yes, sir.
Okay, thank you. Thank you.
Thank you.
As I said, we were not planning to discuss etiology. So we go on to the next case, the third case. Dr. Balveen, who is a second year resident in our department, will present the case. And then I have lots of questions for him. And he will answer those questions. Balveen, can we have your slides?
Yes, sir.
Right.
Good evening to all present. Now continuing further with case 3. So we have 88-year-old gentleman with prior comorbidities of hypertension, diabetes mellitus for 25 years, and coronary artery disease post PTCA in 2006. He comes up with chief complaint of double vision. On awakening, he had difficulty in moving his eyes and had a feeling of painless restriction, more on looking towards the left side. The double vision was binocular, and separation of images were more in the horizontal direction than vertical. There was no vertigo, motor, speech, or any sensory symptoms. Coming to the neurological examination, patient was alert, coherent, conscious, normal higher mental functions.
Hello. 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 There is some, can we all except Balveen, can we all mute ourselves?
Yeah, so going on with the neurological examination, patient was alert, coherent, conscious with normal higher mental functions. There was no facial or limb weakness and no pronator drift. There were diminished sensation and proprioception in the lower limbs, which was attributable to a long-standing diabetic peripheral neuropathy. Otherwise, mobility was independent. Rest of the neurological examination, including testing of limb coordination and plantar reflexes, was unremarkable. The visual acuity was 6/24 in left eye, 6/36 in right eye. Pupil size was 2.5 mm and pupils were sluggishly reactive. The right eye had pseudoaphakia and the left eye had immature senile cataract. So we were not able to elicit a pupillary reaction in our subject. Fundus showed disc and macula within normal limits of both the eyes. Now coming to the extraocular muscle examination, this is the left side and this is the right side. We examined the extraocular muscles in all the 9 cardinal position of gazes. This is the primary position of the eye. And as we can see in the primary position of gaze, the right eye is deviated laterally and upwards. This lateral deviation is called as exotropia and the upward deviation is called as hypertropia. So anything which is manifest is called as a tropia and anything which is latent is called as a phoria. Exo means outwards, iso means inwards, hyper means upwards, and hypo means downwards. So in the primary position, we all can see that the right eye is exotropic and hypertropic. On looking towards the right side, in the horizontal as well as vertical gaze, we see that this vertical misalignment still persists, but otherwise the extraocular movements were well preserved. Whereas on looking towards the left side in the horizontal gaze, we see that there is adequate abduction of the left eye, but there is a palsy in the right eye. The right eye is not adducting, as the right eye is not able to move inwards. On looking at left superior and inferior directions, we can see that there is an adduction weakness, number 1. Number 2, the hypertropia or the vertical misalignment, it is increasing on looking towards the left gaze in both horizontal and vertical directions. So to sum up, there is a right adduction palsy.
there is hypertropia of the right eye, and the vertical misalignment is present in all the direction, but more in the left direction. Now, looking at this image of the subject, we can clearly identify that there is a head tilt towards the left side. And on blowing up this image, we can appreciate that even after the compensatory head tilt, there is still an upward deviation or right eye hypertropia. Now we can see vertical misalignment in neutral left head tilt and right head tilt also. On blowing up these images, we can see that the vertical misalignment, it increases on the right head tilt and decreases on the left head tilt. So in the neutral position, we have a vertical misalignment which increases on right side and decreases on the left. Now to see extraocular muscle examination video. So in the primary position, notice that there is a head tilt towards the left side and the right eye is hypertropic. Now I'll play the video. Now here we see a torsional nystagmus in both the eyes. I'll repeat the video again. So we can appreciate the torsional nystagmus in both the eyes. Now we ask the patient to look towards the left side. And on looking towards the left side, we see that the left eye is adequately abducting, but there is a right eye adduction palsy with a horizontal dissociative nystagmus in the abducting eye. Rest other gaze movements were normal. This is on looking towards the right side. Then superiorly up. And down.
Okay, Balveen, I have a lot of questions for you.
Right.
Your patient had both horizontal and vertical diplopia.
Yes.
Right?
Right.
So can you tell me what are the causes of a binocular vertical diplopia?
So a binocular vertical diplopia can result from lesions of a third nerve palsy, a trochlear nerve palsy, a vertical skew or an ocular tilt reaction, any local orbital pathology, or myasthenia gravis.
Right. So basically, let's please keep that slide. Can we go back to that slide? Yeah. A vertical diplopia involves one of the vertically acting muscles, right? What you mean to say, Balveen? Am I right?
Yes, sir.
That means in the abducted position, the superior rectus and the inferior rectus, and in the adducted position, the inferior oblique, which elevates the eye, and the superior oblique, which depresses the eye, right?
Right.
Right. And because the third nerve supplies both the superior rectus, the inferior rectus, and the inferior oblique, the trochlear nerve or the fourth nerve supplies the superior oblique. So you can get a vertical diplopia in both in a third nerve palsy and a trochlear nerve palsy. In addition, there is this phenomenon of vertical skew. And Balveen is going to tell us what this phenomenon of vertical skew is a few slides, a little while later. And that is something that we really need to keep in mind. Plus, of course, there can be a local pathology and local lesions, nerve lesions, and so on and so forth, right? Balveen, you need to advance the slide. Yeah. So my next question is, the primary action of superior oblique is intorsion, right?
Right.
Balveen, you agree with that?
Yeah, right, sir.
Right. It also depresses the eye in an adducted position. Right?
Yes.
But it is very difficult to appreciate intorsion. And particularly if there is a third nerve palsy, right?
Yes.
Then the issue comes is in a third nerve palsy, how do you demonstrate intorsion? or how do you go ahead and say whether in addition to the third nerve, there is a fourth nerve palsy or a superior oblique palsy?
Right, sir.
So can you tell us how to do that?
Now, as asked by sir, we have a patient here who has a weakness of the adduction of the right eye. So how do we have to check intorsion in the same patient? So here we can appreciate a pigmented mark on the sclera at 12 o'clock to 1 o'clock position. Luckily, our patient had a pigmented mark on the sclera. Otherwise, the best is we can always correlate it with the most prominent subconjunctival vessel in any of the direction. So we see this pigmented mark on the sclera at 12 o'clock to 1 o'clock position. Now we ask the patient to look into the left inferior quadrant. And in an attempted adduction and inferior movement, we can see that there is no change in position of this pigmented mark. It still remains at 12 o'clock to 1 o'clock position, which signifies that there is weakness of the intorters and there is no intorsion in this patient.
Yeah, so it would have rotated medially. This mark would have rotated medially if there was intorsion.
Yes.
And this is just going vertically downwards.
Right.
Due to the action of which muscle do you think so?
Inferior rectus.
Very good. Excellent. The superior oblique you mean to say is palsy.
Paralyzed. Yes.
Right. Excellent. Okay. Right. So now if you tell us that there is a superior oblique palsy, and there is a previous question as to which side to say, whether it is a superior oblique on the right side or left side. The first thing is you have to say which side superior oblique. Now tell us, if there is a superior oblique palsy, which side is the superior oblique palsy, and why do you say there is a superior oblique palsy in this patient?
Right. So step one, we look at the patient in a primary gaze position. In a primary gaze, the right eye or the affected eye is hypertropic. As we ask the patient to look towards the left side, in the left gaze, the vertical misalignment increases. In the right gaze, the vertical misalignment decreases.
Right.
In the neutral position, in the primary gaze, there is vertical misalignment. The right eye is hypertropic. And this misalignment increases on right head tilt. And as a result, we can see in this picture that the patient has a compensatory left head tilt. So 3 points. Hypertropic eye is the right one. Gaze to the left increases the hypertropia, and head tilt to the right increases the hypertropia. These 3 points favor the diagnosis of a right trochlear nerve palsy.
Oh, right superior oblique palsy. You mean.
Right superior oblique palsy.
Okay. Right. Okay. So, ladies and gentlemen, remember these 3 things. In the primary position, look at which eye is hypertropic or which eye is higher. If it is a superior oblique palsy, head tilt to the same side will increase the vertical misalignment, and gaze or head turn to the opposite side will again increase the vertical misalignment. So hypertropic eye is the right eye, head tilt to the right increases, gaze towards the left side decreases, and therefore this is a right superior oblique palsy, right? Let us not say at this point of time whether it is a trochlear palsy.
Trochlear nerve, yes.
Right, okay, right, okay. So I have more questions for you, Balveen.
Right, sir.
There was some adduction deficit you found out, right? So I want you to tell me whether this is because of a third nerve palsy or an INO.
Yeah, right, sir. So there was definitely a right adduction palsy, as we saw in the photographs while doing the extraocular movements, or even in the video. So pupil size and reaction could not be commented, as there was pseudoaphakia in right eye and left eye had an immature senile cataract. But having said that, there was no unilateral or bilateral ptosis. The other muscles like superior rectus, inferior oblique, their functions were well preserved, and the opposite side superior rectus and levator palpebral superioris function was well preserved. The convergence was well preserved. The presence of torsional nystagmus and the presence of nystagmus in the abducting eye on left gaze, these two things point towards a diagnosis of an internuclear ophthalmoplegia. So because of the presence of a torsional nystagmus, a nystagmus of the abducting eye on left gaze, and absence of ptosis, presence of convergence, I would like to entertain the possibility of an internuclear ophthalmoplegia in our patient.
Thank you. Excellent. That's right. Can you advance further? So now there is this thing known as vertical skew, and Balveen and all your colleagues, when Dr. Shah and Dr. Lakshmi and Dr. Bansal and me were residents, you know, we used to think of vertical skew as a very sinister sign. It was considered to be a very rare sign. And at that time, it was only known to occur in moribund patients, patients who were extremely sick, deeply comatose, with a pontine lesion, a pontine hemorrhage, right?
Right.
So that concept has changed now, right? And now we know that vertical skew is a common sign. It occurs in brainstem lesions and a variety of brainstem lesions. It is only that we need to look for this sign. And it has localizing value also. So the first thing I want you to tell us, Balveen, is how to differentiate between a trochlear nerve palsy and a vertical skew, because both of them will cause a vertical misalignment, right?
So these are the few differentiating points which will help us to localize whether the vertical misalignment is because of a trochlear nerve palsy or a vertical skew deviation. Point number one, the eye torsion. Since a trochlear nerve palsy, a trochlear nerve is responsible for intorsion, so there will be an extorsion of the affected eye since the intorters are weak or paralyzed. Now, variations with the head tilt, we have seen earlier, the variation will be there and it will increase towards the affected eye. Variation with the gaze, again, we have seen in the previous slide, they increase away from the affected eye. For example, if the right trochlear nerve or right superior oblique is paralyzed, on right head tilt, there will be increased vertical deviation, misalignment, and on left gaze, there will be increased vertical misalignment. Now, variation between the upright and lying down position will be more prominent in a vertical skew deviation. A patient with vertical skew deviation, the vertical misalignment will decrease when the patient will go down from upright to supine position, which will not be the case in a trochlear nerve palsy. The head tilt in a trochlear nerve palsy will almost always be on the opposite side, whereas in a vertical skew deviation, it depends on the site of the lesion, which we'll discuss in further slides.
Okay, so go ahead to the further slide. So this patient had a torsional nystagmus, right? That
Yes.
video you showed, the first thing that you showed us was a torsional nystagmus. Now tell us, what is the clinical or localizing significance of a torsional nystagmus?
So a torsional nystagmus can be seen with involving the lesion anywhere between the semicircular canal and to all its connection towards the central vestibular pathway. Say, for example, here in this diagram, we are depicting that there is a semicircular canal. So a lesion anywhere starting from the semicircular canal, going in the brainstem, ascending with the medial longitudinal fasciculus, going to the various cranial nerve nuclei which are in the brainstem. A lesion anywhere along this course can lead to a torsional nystagmus.
Right. So the presence of a torsional nystagmus means that anywhere in the connections between the semicircular canals and to the oculomotor nuclei, there can be a lesion anywhere in this, right?
Yes.
Okay. Most often it is the brainstem. So the presence of torsional nystagmus means that there is a brainstem lesion involving the connections between the semicircular canals and the oculomotor nuclei, right?
Right.
Okay, excellent. So What about this head tilt? You can get a head tilt in trochlear nerve palsy, which you showed was your patient had a right superior oblique and the patient had a left. So the head tilt, I presume, is towards the opposite side. But you can get a head tilt in a vertical skew.
Yes.
So tell us which side would be the head tilt in a vertical skew?
So the head tilt in a vertical skew can be both ipsilateral or contralateral to the lesion. It depends on the site of the lesion. As we see here, the fibers, they originate from semicircular canal, goes upward, and they cross in the pons and then ascend upwards. So a lesion which is caudal to the pons will produce an same side head tilt, whereas a lesion rostral to the pons will produce a contralateral head tilt.
Okay, thank you. Right, and then there is this examination of the ocular fundus, which is also a very important sign in the diagnosis of a trochlear nerve palsy versus a vertical skew. So if you can see, this is the optic disc, right? And there is the macula, right? And look at the position of the macula in relationship to the optic disc. Where is it located? It is located somewhere below the midpoint of the optic disc, right? The horizontal midpoint, somewhere between the junctions of the lower half and the lower 1/3 of the optic disc, right? So look at the relationship between the macula and the optic disc in a normal person, right? This is the right eye and the left eye, okay? Now, what happens, Balveen, can you go on to the next slide? What happens in a vertical skew? In a vertical skew, one eye is encyclotorted and the other eye is excyclotorted. So you see the macula has gone above the level of the disc, right? This is the midline of the horizontal midline of the optic disc, right? And this is the lower border of the optic disc, and the macula is clearly above this. That means the eye has rotated like this, right? This is on the hypertropic eye, and the left eye, it's the reverse. The macula is below the level of the optic disc. That means this eye is excyclotorted. In a trochlear nerve palsy, on the other hand, what happens is there is failure of intorsion. So the eye will be excyclotorted, and therefore the macula will be below the level of the optic disc, right? And this is on the right side. The left side is normal here, right? So by doing a fundus examination and looking at the position of the macula in relationship to the optic disc, you can actually differentiate between a vertical skew and a trochlear nerve palsy. So this is something new that we learned, and we were able to demonstrate this in our particular case. Next slide.
This is the fundus examination of our subject that we were discussing earlier.
Okay, thank you.
Now coming to the MRI of the patient.
Right.
So these are diffusion weighted images, blown up images. This is the right side. This is the left side. The first four are the midbrain cut sections. This is the inferior most midbrain, and then comes the pons. So in our patient, we have a lesion at the dorsal most part of the inferior midbrain sections. Now, to localize these structures that we have examined earlier, we have inverted these images and put some drawings to illustrate the tracts and the nuclei. This is the dorsal portion. This is the right side. Now, this is an inverted blown up image. So this becomes right side. This becomes left side. Here, somewhere we have a cerebral aqueduct. This is at the level of superior colliculus. And here are the third nerve nuclei, and medially lying is the medial longitudinal fasciculus. Here is our lesion. And here is the fourth nerve nucleus, which we already discussed in case 1, decussates dorsally inside the brainstem at the midbrain level. At the inferior most midbrain level, we have an involvement of medial longitudinal fasciculus because they are the medialmost structure lying there.
So can you go back to these slides? Yeah, the brain sections. So you have a lesion in, yes, exactly that. So you have a lesion in the lower part of the midbrain.
Yes.
Dorsal on the right side.
Yes.
And that has caused a fascicular right trochlear nerve palsy. Can you show that? This is the lesion, and which is the trochlear nerve palsied? The right
trochlear nerve.
Sorry, this would be the left trochlear nerve.
Yeah, so the right superior oblique muscle supplied by the
left trochlear nerve.
Yes.
Right?
Yeah.
And at the same time, there is an internuclear ophthalmoplegia.
Yeah.
Right?
Which we can explain by a medial longitudinal fasciculus.
And that is on the right side.
Yes.
So there is a very small discrete lesion here, which has caused a right trochlear nerve, a left trochlear nerve palsy, leading on to right superior oblique as well as an internuclear ophthalmoplegia. Is that right?
Yes, sir.
Right. Okay. So go ahead. Do you want to conclude something?
No, sir. Conclusion.
Right. Okay. So, ladies and gentlemen, this is how you go ahead, and these are just extrapolated diagrams of the MRI images, and we have drawn these diagrams on these drawn and extrapolated the brainstem nuclei, the fascicles of the nerve, as well as the tracts on these diagrams. This is a little bit of a hypothetical job, but the subsequent presentation, which is very brief, just 5 minutes, Dr. Nitika will tell us how we do this extrapolation of nuclei and tracts on the MR images, which help us in attaining a very good clinical radiological correlation.
A very
Nitika,
good
please.
evening to all present. First of all, we would like to acknowledge these two papers, which were published in the American Journal of Neuroradiology by T.M. Shepherd et al. And William L. Hirsch et al. So, although these articles, they depicted MRI pictures of the post-mortem brain sections, which were stained, and these were very long studies using some very special sequences on a 7 Tesla MRI. We tried to extrapolate our findings on a conventional 3 Tesla MRI. So these are the axial sections of the midbrain at the level of superior colliculus and at the level of inferior colliculus. So this is just the revision of what Dr. Balveen has just mentioned, that at the level of superior colliculus, we all know there would be a third nerve nucleus and a third cranial nerve. So this third cranial nerve nucleus, it lies dorsally, just ventral to the aqueduct. So there is a one simple rule in brainstem. Almost all the cranial nerve nuclei, they lie dorsally. They are just anterior to the fourth ventricle or anterior to the aqueduct. Most of the cranial nerve nuclei, if we talk about. So same rule applies to the third cranial nerve nuclei and the fourth cranial nerve nuclei. So I'll be just discussing the brief differences between the section of upper midbrain and the lower midbrain. At the level of upper midbrain, that is at the level of superior colliculus, the hallmark feature is the presence of red nucleus, which is very well visible on the conventional 3 Tesla MRIs. So once we find a red nucleus, we are pretty sure that we are dealing with the upper midbrain section. So then the second difference is the presence of third cranial nerve in a superior colliculus level and a fourth cranial nerve at the level of inferior colliculus. So we all know that this fourth cranial nerve crosses within the brainstem after arising from the nucleus. So nucleus is again lying dorsally. So these are the cerebral peduncles. This is the ventral part. This is the dorsal part of the brainstem. So this is the cerebral aqueduct. Here we have third cranial nerve nucleus and the third nerve which exits ventrally. So fourth cranial nerve is the only cranial nerve which exits dorsally from the brainstem and crosses before exiting from the brainstem. So this is an exception. We need to keep in mind that the fourth cranial nerve exits dorsally from the brainstem. So these are the corticospinal tracts, which are the ones which are most ventral. In most of our patients, which we discussed today in Dr. Balveen's case and in the case discussed by me, the lesions were present dorsally. So this explains the sparing of the pyramidal tracts. And another important point is at the level of inferior colliculus, we have this decussation of superior cerebellar peduncles, which we have already explained in our case. So then we come on to the sections of the pons at the level of trigeminal nucleus and at the level of facial colliculus. I'll be just highlighting the salient features. At the level of upper pons, we have the motor and the sensory nucleus of the trigeminal nerve, and that lies just ventral to the fourth ventricle. So we have already explained that most of the cranial nerve nuclei, they lie dorsally within the brainstem. So this is the dorsal part, this is the fourth ventricle. Just anterior to the fourth ventricle and the most medial tract is MLF. Then just anterior to this MLF is the presence of fifth cranial nerve nuclei. And then in between, there is a presence of medial lemniscus, which is very well seen in the level of pons. And these two are connected and crossed by trapezoid body, which is involved in the auditory pathway. So we all know at the level of lower pons, we need to look for sixth cranial nerve, seventh and eighth cranial nerve. So we have already seen fifth cranial nerve, both sensory and motor, they are also exiting ventrally. Same is the case with the sixth and the seventh cranial nerve. So at the level of lower pons, the most marked feature is the presence of facial colliculus. This is again the cavity of fourth ventricle. Facial colliculus is formed by the fibers of the seventh nerve. These fibers of the seventh nerve, which wrap around the sixth cranial nerve nuclei. And that leads to bulge within the fourth ventricular cavity, and that is called facial colliculus. So we have a well-defined section of lower pons at the level of facial colliculus. This facial colliculus is formed by the fibers of seventh nerve, which wrap around the sixth nerve nucleus, and then they exit ventrally from the brainstem. So now we have the three sagittal sections. One is the mid-sagittal section, then just a parasagittal section and a lateral sagittal section, depicting the various tracts of the brainstem. The one which is marked in green color and the most ventral one, this is the ventral side of the brainstem, this is the dorsal side of the brainstem. All the colliculi, they are present dorsally. Superior colliculus, inferior colliculus, facial colliculus, these are basically the bulges within the ventricles. So they are present dorsally. So here we have corticospinal tracts, which are the ones which are present most ventral in location within the brainstem. In all the three sections we can see, and they are very prominent within the pons. Then just at the level of mid-sagittal section, now we have some tracts which are present dorsally. The dorsal tract, which is present exactly in the midline and running throughout the brainstem, is medial longitudinal fasciculus. Then just parasagittal, that is 2 mm lateral cut, if we take, we can find the central tegmental tract. The descending fibers of central tegmental tract are basically rubro-olivary tract. We all know from red nucleus to the inferior olivary nucleus involved in palatal myoclonus. And then the third tract, which we can find out going more laterally, running throughout the brainstem, is the medial lemniscus, which is actually a part of dorsal column or posterior column. So this is the last slide, which is showing the connections of the various brainstem nuclei which are involved in gaze. There are two kinds of gaze, we all know, horizontal gaze, vertical gaze. So the nuclei of the horizontal gaze is present within the pons. So the horizontal gaze center is in pons, that is PPRF, and that is present dorsally, but it is anterior to the sixth cranial nerve nucleus. So I already told that all the cranial nerve nuclei, they lie dorsally. So this is the superior colliculus. At the level of superior colliculus, we have third cranial nerve nuclei. At the level of inferior colliculus, we have fourth cranial nerve nuclei. Within the pons at the lower level, we have 6th cranial nerve nucleus. Here we have 8th cranial nerve nucleus in the lower pons. The connection between the third cranial nerve nucleus, 4th cranial nerve nucleus, 8th cranial nerve nucleus, and 6th, all together is medial longitudinal fasciculus, and which ascends up to the level of nucleus of rostral interstitial medial longitudinal fasciculus. So the only hallmark feature in this slide we can learn is the center for horizontal gaze lies within the pons, and the centers for this vertical gaze, they are present within the midbrain. One is the rostral interstitial MLF, interstitial nucleus of Pahal, and posterior commissure. Lesions of posterior commissure, they are more common and they lead to up gaze pulses, while RIMLF leads to down gaze pulses. Thank you. That's all I have to.
Thank you, Nitika. Just want to reiterate that these MRIs, these two papers which Dr. Nitika had quoted were papers in which MRIs were done in a postpartum brain. And it took an awfully long time, it almost took 2 to 3 hours for them to acquire the MRI sequences. And then they could see all these nuclei and the tracts. We cannot do that in clinical MRI, such long MRIs are not possible. So, but based on these papers, we have tried to draw and extrapolate various nuclei. And whenever we see a patient with a brainstem lesion or a brainstem stroke, just like the 3 cases that we have illustrated and demonstrated here, we always try to extrapolate these nuclei and tracts. It's basically imagining these nuclei and tracts in a 3-dimensional. As she showed, there are axial cuts. We need to understand at which level, at what level of the axis would you expect certain cranial nerve nuclei. And then the sagittal cuts, for instance, in the mid-sagittal cut, she showed that you would get the medial longitudinal fasciculus, while the medial lemniscus and the central tegmental tracts would be seen in a parasagittal cut. So the corticospinal tracts would be seen ventrally. So I mean, if you imagine that and try to extrapolate that and then try to correlate with your clinical findings, that is the message of our presentation today. I'm extremely grateful to the entire faculty of my department, as well as all the residents who have done a lot of hard work in the last few days to basically make this presentation. But this is something which we feel that every neurologist, every resident, every trainee neurologist should actually do. Thank you. I pass on the mic to the organizers, Dr. Lakshmi and Dr. Sudhir Shah, and
Yes,
we'll be happy to take questions.
Thank you, sir. Thank you, sir. Thank you for I really congratulate the entire team led by you, Dr. Bansal, and Dr. all the residents. It was, I don't have any words, a beautiful discussion. And the comments made by so many in the chat box itself reveals that it's an awesome discussion of the various and the cranial nerve nucleus involved in gaze, and excellent deposition of and my sincere thanks to Dr. Monica Singla, who was really made this diploma. I wish that every resident would now start doing it. And not only that, you open to the eye. It's an eye opener for the students to look for the correlation between the various lesions which they see and where to look for the lesion in the MRI. So this is all extraordinarily great session we had, and my hearty thanks to the team from the Iron Medical College, Ludhiana, and every one of you. I'm my hearty thanks to that to make this an excellent session. And before I invite Professor Sudhisha, I'd like to announce that the next neurological secret, the last week of March 26th, the scene moves from Ludhiana to Trivandrum to Professor Madhusudan. Madhusudan and his team will take the next localization on March 26th. And I now request Dr. Sudhir Shah to conclude the session. And my hearty thanks to Arun Chadda and his team and every one of you and all the participants. Thank you so much.
Thank you, Dr. Lakshmi, for concluding remarks. And it was indeed a great session, terrific clinical localization in a very narrow area, that is brainstem, crowded area, and so detailed discussion about anatomical localization with radiological superimposition. And of course, new learning of diplopia for students. I think it was indeed a great session as promised by Dr. Gagandeep Singh and his team. And as we mentioned earlier, this is the first session on brainstem localization in our series. So I think in that way, this becomes a unique webinar. I must congratulate all the participants, including Professor Gagandeep, Professor Paul, Dr. Monica Singh, and all others who have, and the students particularly, who have done their great job. Thank you to the participants, delegates, and of course to Mr. Arun Chadda on behalf of the JAS Pharmaceuticals. I now invite Mr. Arun Chadda to give Thanksgiving. I also want to thank Dr. Haley, Dr. Manoj Kumar, and others. Thank you once again. We await for the next meeting, last Friday every month. So next month we meet on 26th of March. Thank you.
Thank you, sir. And it's really great that we are at the end of the 8th session of the Secret of Neurology web series. Turned out to be very successful. Pharmaceutical would like to propose a hearty vote of thanks to all the honorable delegates who blessed us with their presence. It's audience like you that makes presentations awesome. Thank you very much for your unwavering attention throughout this presentation. First of all, I would like to thank our honorable course director, Dr. Lakshmi Narasimhan sir, Dr. Sudhir Shah sir, for designing such a fantastic web series on neurology, which will be very helpful to all the DM and DMB students. A million sincere thanks to Dr. Gagandeep sir for the sea of wisdom and the knowledge sir has showered to all the DM and DMB students. With your expert comments and explanation given to each and every case, sir. Sir, you are too excellent. I would like to thank to our young neurologist, Dr. Dr. Venkatesh, and Dr. Nitika Mahajan and Dr. Balveen Singh for presenting the cases. Further to this, I would like to thank to the entire DMC Neurology Department, Dr. Monica Singla ma'am, Dr. B.S. Paul sir, Dr. Rajinder Kumar Bansal sir, and Dr. Gagandeep sir for presenting such a unique cases with fabulous presentation and which will be extremely helpful and informative to all the participants. Once again, thank you for your gracious presence, and it's being a pleasure being with all of you today. Thank you all your patience, and I wish you all a very good night now with the promise that next month, 26 March 2021, we will meet with the most awaited next session of Secret of Neurology. Till then, stay safe, take care. Thank you, sir.
Thank you, Arun. Thank you, Arun, for
thank you, sir. Thank you.
Thank you, sir. Thank you so much.
Thank you.
Thank you, Heli.
Thank you,
Thank
Dr.
you,
Lakshmi.
Dr. Shah and Dr. Lakshmi.
Thank you. Thank you, sir. Thank you. Thank you, ma'am.